I want to introduce myself really quickly. My name is Rachel Lieberman. I'm a director here at the Celiac Disease Center, and we are so thankful you are here with us today. And we have a really robust discussion on the spectrum of celiac disease and the response to the gluten-free diet. I would like to thank all of our speakers and moderators and panelists from around the globe. This international presence is fantastic, and we would not be able to put on this type of education without you. So thank you very, very much. And of course, we need to thank our sponsors for today, the Celiac Disease Foundation and Karen and Eric Simon. Just a few housekeeping notes. If you are having any technical difficulties throughout this session, this is the email. You please note this email. It's also in the welcome email you received from me earlier today, but they will be able to help with anything you need. I just want to note our Q&A function at the bottom of this Zoom is where you'll be submitting questions for our speakers. So please know that we will be addressing them. What's wonderful is we have a Q&A moderated panel after our two speakers present, and so we will be addressing those questions then. As far as your CME, you will be getting your credit information. At the end, I will be sending an e-blast about that. And this session is obviously, it is all being recorded, and it will be on the virtual conference website probably by Tuesday or Wednesday. But right now, I would like to turn things over to our medical director of the Celiac Disease Center, Dr. Ritu Verma. Thank you, Dr. Verma, and I will let you take it from here.
Thanks, Rachel. Thank you, everyone, whoever is joining us again. I hope people are joining us from the morning session, but just to remind everyone, we'll have a couple talks and then a roundtable. But before we start off with the talks, it is indeed a pleasure and an honor to introduce my co-moderator, Dr. Khosla, who is the Mark and Jennifer Lipschultz Director of the Stanford Innovative Medicines Accelerator. He's also the professor of the departments of chemistry and chemical engineering at the Stanford University, and he will be co-moderating this session with me. So Dr. Khosla, we're going to have fun in this session. So this session is all about diagnostics in celiac disease. And our first speaker, again, indeed a pleasure to introduce Dr. Maureen Leonard. She is the clinical director of the Center for Celiac Research and Treatment at Mass General Hospital, an assistant professor of pediatrics at the Harvard Medical School. A dear friend, Dr. Leonard is going to talk about diagnostics in children with celiac disease. Maureen, take it away.
Thank you so much for the invitation to speak. I'm really honored to be here. It's been a great morning. I've learned a lot, and I'm excited to keep it going this afternoon. So today I'm going to talk about diagnosis of celiac disease in children. I have a couple of disclosures here, but they aren't related to what I'll be speaking about today. And today I will be focusing on reviewing the diagnostic criteria for children with celiac disease, and also discussing the non-biopsy approach for the diagnosis of celiac disease in children. And I want to provide just a little brief background. You've heard some of this, but we know that for many, many years, celiac disease was really considered a pediatric gastrointestinal disorder, which presented between 9 and 24 months of age with complaints such as abdominal pain, diarrhea, bloating, weight loss, and irritability. However, the development of non-invasive and accurate diagnostic serological tests that allowed for screening of large populations of people for celiac disease really led to the recognition that celiac disease is a truly systemic autoimmune condition. And so for children, we know there are a variety of signs and symptoms beyond the gastrointestinal manifestations, such as short stature, which we heard from Dr. Stahl may affect up to 10% of pediatric patients with celiac disease. These patients may present with delayed puberty, dental enamel defects, and behavioral changes that really have the potential to significantly impact social development and learning. So today, due to increased awareness and these available serological tests, even our youngest patients with celiac disease may look very different than the textbooks, and they may not have the signs of malnourishment or irritability like this child, who was diagnosed as part of one of our ongoing prospective studies. And so it's not just that we're recognizing this heterogeneous presentation of celiac disease. Literature really supports the clinical observations that pediatric celiac disease has changed. Both Dr. Adams and Dr. Stahl already pointed out that the majority of children now are of normal weight at diagnosis, and nearly 1 in 5 may have overweight or obesity, but the minority really are underweight at this point when they present. Studies show that the symptoms and histology findings may be less severe when compared to 15 to 20 years prior. And children are older at diagnosis. So this graph here shows the mean age at diagnosis in 1970 compared to 2015. And you can see even from a distance that there's an increasing average age, which in this study in Sweden increased from age 2 to age 8 over a 45-year period. Finally, we know that extraintestinal manifestations are common. These symptoms, which are things like anemia, fatigue, skin rash, headache, joint pain, among others, they're often the presenting symptom in children, and they're equally prevalent in adults. The presence of these symptoms has also been associated with a slower rate of healing or improvement once on the gluten-free diet. So since 1980, there have been numerous diagnostic tests for celiac disease that have been developed. And there are several tests that we can order, but sort of fewer that we focus on at diagnosis. So I want to highlight the tests that are most used today, and then we'll work through the diagnostic algorithms that are available. So the test that's typically sent for celiac disease is the IgA tissue transglutaminase test, or the IgA TTG. And this has a sensitivity of about 70 to 100% and specificity of close to 80 to 100%. And so this is the first line screening test for celiac disease because it's easy to obtain and order. For patients that have a IgA deficiency where we can't use this test, we send an IgG deamidated gliadin peptide, which has a high sensitivity and specificity in patients with IgA deficiency. And finally, in certain cases, we may use the IgA anti-endomysial antibody test as a second line confirmatory test for celiac disease. And I'll highlight some places where we might use that. So looking at the diagnostic approach to celiac disease, when a healthcare practitioner identifies signs or symptoms that they deem concerning for celiac disease, or if they identify a patient that belongs to a high risk group, so a patient with a family member with celiac disease, or who may have a genetic condition that increases their risk to develop celiac disease, or another autoimmune condition that increases their risk, then we send a total IgA level and an IgA tissue transglutaminase. If that test is positive, if total IgA is sufficient, so greater than 7, and IgA TTG is positive, then the recommendation is to perform an endoscopy with duodenal biopsies. And if we see that there is an increase in intraepithelial lymphocytes and villus blunting, then we can confirm a diagnosis of celiac disease. If instead our biopsy doesn't show those classic signs of celiac disease, then we consider sending that second anti-endomysial antibody test to get some more information. We may repeat the IgA TTG, and we may consider sending celiac genetic testing. And this is a patient who we may consider to have either celiac disease autoimmunity or potential celiac disease, meaning they have the serology that's positive for celiac disease, but we don't see the classic changes of celiac disease when we look at their biopsies. If a patient has these concerning signs or symptoms and their TTG is negative and they have a normal IgA level, then we think celiac disease is unlikely. However, there is an entity called seronegative celiac disease where patients can have normal serology tests and still have celiac disease. There are also cases where patients have symptoms that are concerning. That's why we tested for celiac disease in the first place. And so we may want to move forward with an endoscopy to look for celiac disease or other upper GI issues that can cause some of the belly pain or other symptoms that they're presenting with. Again, if the patient has a negative IgA-TTG, but their total IgA is deemed insufficient, then we would use the IgG deamidated gliadin peptide. And if positive, we'd move down the diagnostic algorithm, performing a duodenal biopsy. And clinical practice guidelines from both Europe and North America recommend obtaining at least 4 biopsies during the endoscopy in the distal duodenum and 1 to 2 in the duodenal bulb to maximize the chances of making an accurate diagnosis. But the diagnostic approach to celiac disease, at least in children, is not universal. So all groups in Europe and North America agree that the first step in evaluating for celiac disease should be performing that total IgA level and an IgA tissue transglutaminase. We've gone through the algorithm for that's recommended in North America, where if that TTG is positive, we perform an endoscopy. But in Europe, there are non-biopsy criteria, which have been evolving over the past decade. So we'll look a little closer at those. So the criteria for the non-biopsy diagnosis in children have changed recently. So in 2012, the guidelines required that a patient be symptomatic, and specifically that they have symptoms of malabsorption, such as abdominal pain, diarrhea, weight loss. They were required to have an IgA-TTG level that's greater than 10 times the upper limit of normal. And the upper limit of normal does vary from lab to lab, but as long as it's 10 times higher. They need to have an IgA EMA test that's positive on a second blood sample, so drawn at a separate time from that initial positive IgA-TTG. And they had to have compatible celiac genetics, so a positive HLA-DQ2 or DQ8 genotyping. But in 2020, so about 3 years ago now, the criteria were simplified to now include just having a positive IgA-TTG that's greater than 10 times the upper limit of normal, and a positive EMA on a second blood sample. Just those two are enough in certain situations to make a diagnosis of celiac disease in children. They left whether a patient needs to be symptomatic as a sort of gray area for further discussion. So, and who is not included in these pediatric ESPGHAN 2020 non-biopsy approach? So as I mentioned, whether symptoms are needed is a gray area. The guidelines suggest that in patient that does not have symptoms but does meet the criteria for a non-biopsy diagnosis, that there be shared decision-making between the family and the gastroenterologist to determine whether a biopsy should be obtained. The non-biopsy guidelines should also not be applied to patients with an IgA deficiency, as these guidelines haven't been validated for IgG-based tests. And they can't be applied to patients with type 1 diabetes, as there's insufficient data. So this non-biopsy approach hasn't been universally adopted in North America, but there are still many that are using this non-biopsy approach. Recently, Arun Singh, Dr. Singh from CHOP, led a survey about the North American celiac disease practices, and he found that 50% of the respondents do use the non-biopsy approach. And of those, about 64% applied it to patients who were both symptomatic and met criteria for the non-biopsy approach. 30% of these individuals applied it to patients who met the criteria strictly. And then there were 8 individuals that went rogue and were not sure what they were doing. But this survey was asking this question particularly around the COVID-19 pandemic as well, and it found that even more gastroenterologists were using this during the height of the COVID-19 pandemic for a couple of reasons. One, because the guidelines were sort of streamlined in 2020, and it allowed for sort of not having to order those celiac genetic tests, which can be very costly for patients. It also was utilized more because many of the endoscopy units were shut down during the height of the COVID-19 pandemic to have more room for other patients that needed it. And then there were concerns at that time about coming to the hospital and family preference. And I think Dr. Murray mentioned this earlier, just about a month ago, the American College of Gastroenterology published updated diagnosis and management guidelines for celiac disease. And the main point was that overall, they still do recommend an endoscopy with biopsies to diagnose celiac disease. They do suggest that one could consider the non-biopsy approach with it if there's a high level of IgA-TTG and a positive anti-endometrial antibody in a second blood test. They said in adults that should be reserved for patients unwilling or unable to undergo an endoscopy. However, this non-biopsy approach again hasn't been officially accepted or endorsed by the North American Society for Pediatric Gastroenterology and Hepatology and Nutrition, as more data in North America is needed. So now that we've reviewed sort of the two options and the two algorithms to make a diagnosis of celiac disease in children, I did want to circle back to this table that I showed earlier to sort of the serologic studies to diagnose celiac disease, because I only mentioned the IgG deamidated gliadin peptide test very briefly. I'll highlight that one, and that is the one that is used when a patient has IgA deficiency, which is in about 2% of patients with celiac disease. However, there are some cases where institutions or physicians will order a celiac panel. And with a celiac panel, often all tests will come up. And so there is a chance that we have some of these tests, the DGP, IgG and the IgA DGP, where they sort of come up and they're included and we see the results from this. So this again depends on physician practice, but the data surrounding the use of the deamidated gliadin peptide at diagnosis of celiac disease is complicated. And so they're really not mentioned in the diagnostic algorithms that we have to date. But I did want to briefly just highlight some of the literature around the deamidated gliadin peptide. So as I said, the case for using it is a bit complicated. Several studies have evaluated using the deamidated gliadin peptide studies as a screening test for celiac disease in patients without IgA deficiency, but just as a general screening study. The first found that if in patients that had a normal IgA level and just a moderately elevated TTG, so not extremely high, but still positive, that if you were to add the DGP studies, the sensitivity and specificity were about 87% and 56%, suggesting it sort of lacks specificity and doesn't provide additional info about whether or not to biopsy. That same group found that when patients had an isolated elevated IgG DGP, when IgA TTG was negative and IgA levels were normal, that the positive predictive value of having celiac disease was only 2.8%. Again, suggesting that the addition of IgG DGP is of limited value at diagnosis. And a similar finding was reported a few years ago as well. There was an additional study by the group here at University of Chicago in collaboration with Boston Children's, who found a higher frequency of patients with celiac disease who had an isolated elevated DGP and who did have celiac disease. So again, the data here is pretty mixed. But there is some to suggest that there may be a limited value, and that may be why it's not included in these diagnostic algorithms. So while there may be some low utility for DGP in screening for celiac disease, on the other hand, there are several groups that found IgG DGP may be useful as an early marker of celiac disease. So in one prospective study in children in Finland, up to 73% of these children were found to have an elevated deamidated gliadin peptide before their IgA TTG turned positive. And this was a similar study that then focused on children under age 2, found similar findings. However, another prospective study, the TEDdy study group, which we heard Dr. Stahl talk about earlier, did not find this, but did find that the deamidated gliadin peptide study seemed to resolve sooner than the TTG when patients are on a gluten-free diet, leaving the question that maybe this could be used as a marker of mucosal recovery. I think this gets back to some of what was discussed by Dr. Murray as well, is are there different cutoff values that we need in order to be able to maybe someday use serology as a real marker of mucosal recovery. So we've recently published some work from our ongoing prospective longitudinal cohort study called the CD-GEM study. This is a study that follows more than 500 children at risk of celiac disease from birth and collects blood and stool and information in the attempt to identify predictors of celiac disease onset. We recently utilized a subgroup of about 300 children who had 3 serial blood draws leading up to their ultimate diagnosis, or 3 serial blood draws in general. We identified 38 that developed celiac disease autoimmunity, and we analyzed the dynamics of IgG-DGP, or deamidated gliadin peptide, in these children. And we found that there was a rising IgG-DGP, and that predicted celiac disease autoimmunity in more than 2/3 of cases. And we saw that it predicted this even 9 months prior to diagnosis, so a median of 9 months prior to diagnosis. And when we used a cutoff value, so again, we used a different cutoff value than that that is used to diagnose celiac disease. So we used a cutoff value of 10, and we found that there was a sensitivity of about 74% and specificity of 85% to predict celiac disease autoimmunity. So our data is also in agreement with some of the previous data suggesting that IgG-DGP may represent an early milestone for the majority of at-risk children that develop celiac disease. So we don't know of any other marker that can do this, but perhaps either using this marker alone or even together in a sort of multidimensional algorithm to then predict celiac disease remains sort of a possibility. So now that we've discussed the serology in detail, I wanted to briefly mention what other tests should be performed at celiac disease diagnosis based on sort of expert guidelines. So there's agreement between North America and Europe and that all the following studies should be done at diagnosis. So CBC, iron profile, hepatic function panel, thyroid, calcium, vitamin D, B12, and one should consider hepatitis B testing. It's not necessary to obtain a bone density scan in children according to the expert guidelines, except for symptoms of severe malabsorption or symptoms suggestive of bone disease. So in thinking about sort of the future of diagnostics in children, I'm excited about their next talk. I think there's a focus in children for finding less invasive techniques that could evaluate the small intestinal mucosa without requiring anesthesia. That might mean the use of video capsule endoscopy, transnasal endoscopy, or a tethered capsule endomicroscopy, so a capsule on a string. This could also include new serum biomarkers or using the microbiome and metabolome and other omics to predict celiac disease onset. So to summarize, the clinical presentation of pediatric celiac disease has changed. Celiac disease diagnosis in children still requires an endoscopy in North America, but there are criteria for a non-biopsy approach. Those include an IgA-TTG greater than 10 times the upper limit of normal and an IgA-EMA at a second time point. We reviewed the studies that should be examined at diagnosis, and future diagnostic testing aims to focus on less invasive techniques as markers that could predict celiac disease onset for primary prevention. Thank you.
Should I take over here, Dr. Verma?
Yes, Dr. Kosu.
Good afternoon. It's a pleasure to introduce our second speaker, Professor Knut Lundin from Oslo University. Professor Lundin is a distinguished gastroenterologist in Norway and in the world. His early work not only helped us develop rigorous methods for biopsy evaluations of celiac patients, but also more importantly led to the discovery of disease-specific T cells in patient biopsies, which in large part changed our perspective of celiac disease from being a digestive disease to an autoimmune type of disease. More recently, he's been at the forefront of setting new standards for defining celiac disease, and I suspect he'll be telling us some about his perspectives from that work. Knut, all yours.
Thank you, Shaitan. Thank you. Let me share the screen here. So thank you very much. And to all friends in the celiac field. This is my introductory slide. It's a fantastic world, digital world. So right now we are in the middle of nowhere in Norway and training our dogs. And it's really freezing cold outside. Shaitan, do you hear me and you see my slides?
Yes.
Could you please?
Yes,
yeah, thank you. So let us. I split this into two parts. First, how to diagnose an individual, an adult, on a gluten-containing regular diet, and then afterwards, how to diagnose an individual already on a gluten-free diet, and not the least, do we have some research tools that are ready for the clinics that can be used as of today. Of course, we are concerned about diagnosis of celiac disease. We should diagnose it correctly, economically, and definite. In the sense that we want to save our celiac patients from hard endpoints, but we do not know exactly what the hard endpoints in untreated celiac disease are. Of course, no RCTs have been done. In many cases, diagnosis is simple, but of course, still we have a problem with serology and biopsy reading, which is not sufficiently standardized. Another big problem is that many patients have taken away gluten from the diet before they come to the healthcare system. And lastly, I must also say that many clinicians do not adhere to guidelines. And in the previous talks about this session, I just think there are many aspects that we are talking about as expert in celiac disease, but it turns out my view is that this must be quite difficult for the general practitioner or the general clinical doctor out there. Firstly, let's talk a little bit about cutoff in biopsy and serology, and we're going to dig into this aspect of serology-based diagnosis in adults in some later slides. But just to remind you about an aspect of cutoff here. These are different villus architectures: the normal, the Mars 0, the Mars 1 criteria type of lesion, the Mars 3A, and lastly the Mars 3C. And if you combine these different Mars types with serology, you come up with different scenarios. This is not really straightforward. In many cases, a Mars 3 lesion, which is these two slides, and positive serology, you would say that yes, you have a definite celiac disease. And on the other part, if you have a Mars 0 lesion and negative serology, you said definitely healthy. And then between these scenarios, you have a different of other scenarios with histology and serology, and which is not easy, often not easy in clinical practice. Let me also remind you about a big controversy within this field, and this I've termed it is the Michael Marsh legacy. Michael Marsh was a fantastic pioneer in this field. Died unfortunately some very few years ago, and he convinced us all that celiac disease is a dynamic mucosal lesion, and some people develop the villus atrophy and some do not. What he stated, and many people will some people, some investigators will agree that is that if you have celiac disease, no matter what, you should start treating the patients. But what is really the threshold here? When is a celiac? And what is the lower threshold of what we can say this is a celiac patient? And the lower, in all the kind of diseases, the lower you put the threshold, the more people without overt disease you will pick up, and you will end up in problems. Let me address a little bit of these problems. This is the history of Jonathan. He was 16 years old. I saw him just a few weeks ago. His mother is a rheumatologist, and she asked me, there was such a long waiting list for the endoscopy among the pediatricians. So I said, well, come on, if it can tolerate endoscopy with local anesthesia, we can take him in a couple of days. He had a negative serology a couple of years in the past, so negative anti-TG2, anti-DGP. He had a family history of celiac disease, increasing abdominal pain, positive serology, not high, just above cutoff. He tried gluten-free diet for a short period, just a week or so, rapid response. So he was very eager. He's a very reasonable guy. What did we find? Well, endoscopy, I could see villus atrophy in the bulb and normal in the more distal duodenum. Serology, as you can see, this is borderline values, 4.6, just above the cutoff. And anti-DGP 28. We don't like the IgG, DGP, especially at these levels. It's useless, I think, but we receive them. What about the biopsy? Bulb, Mars 3B. In the distal duodenum, Mars 0. And he is just so eager to start with the diet. And of course we say, yes, you have celiac disease, but look at these values. How is it possible? And this directly addresses the topic of the bulb biopsy. In the past, we used to avoid them because the villi are often short, Brunner glands. You can have exposure to Helicobacter, NSAID, etc. But current guidelines say 4 distal biopsies, 2 from the bulb. It does increase the diagnostic yield, but some are concerned. And how on earth, that's my question to you down here, how on earth can a disease only affecting the bulb give any clinical problems? I just wonder. And this leads me to the other aspect here, our whole thinking, our whole concept of celiac disease. Before, some few years ago, you would say that, oh, celiac disease, it's a slow T-cell activation. Celiac disease is a result of villus damage. You can look at this. And we thought that anti-transglutaminase 2 in the blood was derived from gut plasma cells. Yeah. After 2019, we know that gluten challenge induces a rapid activation of CD4 positive T cells. And we also know that if you inject gluten peptides, you have a very strong reaction, interleukin-2 reaction, you have abdominal pain. And we also know that origin of serum antibodies is not from the gut. These are studies mainly from Bob Anderson's group and Ludwig Solid's group and my own milieu. And so my conclusion so far is that celiac disease is a systemic response and nothing to do with villus damage. Of course, the intestine is involved, but it's not necessarily a villus disease. This may be provocative and we can discuss it. And furthermore, we have a very wide spectrum of pathology in celiac disease in terms of serology, in terms of villus atrophy, but still we treat all our patients equally with a gluten-free diet. And this is completely different from other gastrointestinal disorder. I mean, if you have a patient with ulcerative colitis or Crohn's disease, you would say, oh, how severe is the disease, how should we treat this patient, and if it's severe disease, we use different drugs, active drugs. But in celiac disease, we don't discriminate. This is strange, and this needs to be addressed, I think, in the future, although it is very difficult. Let's go to diagnostic criteria in adults. I have had the pleasure of writing together with other very talented people, especially Abdul Altoma from Amsterdam. The current guidelines, European guidelines, we published this in 2019. It was also transformed to an app which you can download on iPhone and Android. I think these are nice guidelines. More than 100,000 downloads, so a lot of people have been reading this. At that time, we insisted that to make a diagnosis, you need to have a biopsy, strictly speaking. Without a biopsy, you cannot make the diagnosis. That was in 2019, but things are evolving, and data are accumulating to show that this is not necessarily correct. And I want to mention two different publications here. On the left, you see from Jeffrey Holmes in Derbyshire, in Derby Hospitals, from the let me see, what are they? It's from early stage, some few patients that were diagnosed with celiac disease based on biopsy. And in the last years, he has completely gone over to use serology in a more or less majority of cases. So this is anecdotal, of course. This is one general or one practice. I'm pretty sure, or I'm confident that he is doing very well for his patients. So in this setting, serology-based diagnoses have taken over for the biopsy-based diagnosis. And on the right here, the recent publication from David Sanders and a lot of co-authors, including US co-authors, showing that if you have really high levels of antibodies, more than 10 times upper level of normal, as for children, the likelihood that you have villus atrophy is very, very, very high. So based on this data, you would assume, or you would suggest, that serology-based diagnosis is safe and can be really done. There are some problems with serology-based diagnosis, which we can discuss in the next slide. I came across a nice overview of different diagnostic approaches in World Journal of Gastroenterology. I encourage you to read it. This formed the basis of a roundtable discussion that we had during the Sorrento meeting. You know, we convened in Sorrento during the International Celiac Disease Symposium in October. The leaders of the conference, Riccardo Troncone, Carolina Ciacci. And these are from the slides from the different countries. There were mixed responses. Nordic countries are divided. Norway and Denmark say no to a serology-based diagnosis. Finland and Sweden say yes. Italy, UK, Argentina, India say yes. Germany, France, and US, no. So this is an ongoing discussion, and I think we should still discuss it. I used to be very active against serology-based diagnosis. I'm not so sure anymore, so to say. So let's switch gear a little bit and go from the patient that are on a gluten-containing regular diet, and then go to a patient which is already on a gluten-free diet. If you don't catch the patient very early after start of the gluten-free diet, you should not go. You cannot trust serology and biopsy because things heal. First step: do HLA typing. If it's negative for DQ2 and DQ8, stop. This is the main reason to do, or the only reason I would say, to do HLA typing in workup of celiac disease. If it's possible, well, then advocate a gluten challenge for at least 2 weeks, although I think honestly that's too short. 4 to 6 weeks followed by biopsy. After 6 weeks with gluten, you will not find positive serology. This is due to B cell biology. It takes longer time for B cells to transform from native to active plasma cells. Then what about experimental add-on diagnostics? Where does this stand? On the top here, I've listed several approaches. I will not discuss them much, other than to say still anti-TD2 and EMA testing. For me, this is two parts of exactly the same biological phenomenon. So I don't understand why many people insist on doing EMA testing. But the last two things, HLA-DQ gluten tetramers with or without gluten challenge and cytokine release after gluten challenge, these are viable approaches, and we're going to discuss them a little bit. First, tetramer analysis. Tetramers detect T cells, pathogenic T cells in the blood or a biopsy. It's a reagent that we made in our lab, in Ludwig Solid's lab, around 2000, in fact, so they have been around for quite a long time. They are difficult to work with, but they are extremely powerful in picking up disease-specific T cells, for instance, in blood. And Vika Sana published in 2018, that's already 5 years ago, that the tetramers can distinguish gluten sensitive versus treated celiacs. This is the upper panel here. Treated celiacs, all of them have positive cells, apart from this gentleman, in fact, who didn't, in fact, he most probably he doesn't have celiac disease at all. And then some gluten sensitive individuals, most of them don't have these cells. And in untreated celiac disease, you have even higher numbers. In controls, you have low numbers, although there are some individuals with positive cells. And in fact, these individuals in most of the cases turned out to have undetected celiac disease. So this is a powerful tool. You can work with them. You can show that a gluten challenge, a 3-day gluten challenge, induces activation of these disease-specific T cells. This is work done by Stephanie Sülke when she was in the lab, and it turns on all the T cells, all the disease-specific, more or less pathogenic T cells. And you find induction of interleukin-2, which I'm going to come back to. Not only we, but others as well. Maureen, you did this excellent study showing that a short gluten challenge induces tetramer positive T cells at day 6. So this is robust, but we don't offer it for regular use. There is a company making, let me just also add in that we have tried to commercialize the test with the tetramers. It has not been successful, so we have abandoned it. But there is a company making tetramers. They have a large catalog of HLA class 1 and class 2 tetramers, but none focused on diagnostic purposes. And maybe there are some patent issues around here, but maybe it will come. They obviously have a very robust platform. Interleukin-2 is after a single gluten challenge is promising. Pioneered by Bob Anderson group, showing that if you give a celiac a load of gluten, after 4 hours you have a good signal, but it demands a super sensitive assay system, which is available, and it's easy to work with. So this is a robust system. Those patients who vomit have high levels. Those who do not vomit, they don't have as high level as those who are really sensitive to gluten. We did a study together with Jason Tydin and Bob Anderson as well, and we showed that this test distinguishes very nicely celiac disease patients who receive gluten challenge versus so-called non-celiac gluten sensitivity patients that do not react with this test. So I think this test holds some promise, and it needs to be confirmed in larger and independent data sets. And I think lastly, what is really one of the things that I foresee will be a game changer in this field is proteomic-based approaches on biopsies, maybe on serum, maybe on blood as well. Just check out Jorunn Stamnes' excellent work on PubMed, promising as a tool in follow-up, in complicated cases, in readout in clinical trials. And this was one of the major things that Peter Green and I discussed in our recent commentary in Gut. So this is the wrap-up. Most guidelines still insist on the combination of biopsy and serology for diagnosis. Clinical signs are a little bit old-fashioned, although as a clinician, I would always pay attention to the patient's need. There are several national guidelines now allowing serology-based diagnosis in adults, but no international widespread guidelines. The question still remains, will serology-based diagnosis lead to more misdiagnosis? Not if it's done properly. And lastly, experimental diagnosis is possible if already on a gluten-free diet, but the tetramers are not commercially available. Interleukin-2 in serum after gluten challenge are promising, and maybe proteomics or in-depth analysis will also help us. And lastly, let me thank my collaborators, and in particular Ludwig Solid, my friend during several decades of research. So thank you very much.
Thank you very much, Dr. London. At this time, I'd like to invite the rest of the panelists to join us. So Dr. Joe Murray, who was already in our first session, and just to remind everyone, not that anyone needs reminders, but he is a professor of medicine at the Mayo Clinic. And Dr. London, you'll stay on. Dr. Tronconi, welcome. We haven't heard from you, but welcome to Chicago. Dr. Tronconi is a professor of pediatrics at the Department of Medical Translational Sciences of the University of Federico in Naples. He's also the director of the resident program, and he's director of the European Laboratories for the Investigation of Food-Induced Disease at the university. I'm sure there are many, many more things that Dr. Tronconi is doing, which I'm not probably really paying full justice to, but welcome. Dr. Guandolini, haven't seen you in a while, but Dr. Guandolini again needs absolutely no introduction, but just a brief introduction here. Professor Emeritus here at the University of Chicago, founder of this center, founder of the basis of this center here in the University of Chicago. And really it's been a privilege getting to know Dr. Guandolini and being here at the center and learning what he has done. Besides that, I think there's been a lot of things that Dr. Guandolini has been president of, various societies, as I learned, including the Italian Society for Pediatric GI, Hepatology and Nutrition, and the European Society. And he's also the founder and first president of the Federation of the International Societies for Pediatric GI and the North American Society for the Study of Celiac Disease. And again, I'm definitely not doing full justice, but Dr. Guandolini, really good to see you. And Dr. Leonard is part of the panel as well. I'm going to hand it over to Dr. Koschler.
Thank you. It's great to have such a distinguished panel to discuss the future of diagnostics. Maybe I can start by asking each of you, and I'd like to go in alphabetical order if that's okay, starting with Stefano. When you look at how rapidly diagnosis is evolving, what are you most excited about when it comes to celiac disease diagnostics? And I think just for the sake of discussion purposes, we can think of diagnostics as a bundle, including both new diagnostics suitable for new diagnosis as well as for ongoing disease management. So Stefano, what are you most excited about?
Well, first of all, I'm most excited by the progress that the diagnostic process for celiac disease has seen through the years. even though I was still in the medical school, I remember that in 1969, maybe some of the older people around here might also remember the Interlaken criteria were put forward by the European Society for Pediatric GI there. And they called for 3 biopsies. So the first biopsy at the time of the disease, then you would put the patient gluten-free, patient improved, you let him grow and be happy for 1 year, and then you made him very unhappy by first doing a second biopsy to show that the intestine has really healed, and finally made him unhappy with going back to gluten, and then finally doing the third and last biopsy. So the whole diagnostic process took about 1.5 years, and it implied reproducing the disease in the patient. So that was really cumbersome. This was changed about 20 years later when in Italy, Riccardo might remember well, we did a multi-center study showing that indeed, if you have 1 biopsy with support of the laboratory and the clinical data, that would be enough in diagnosing without hesitation, so to speak, celiac disease. And then finally, 20 years after, it appears that every 20 years, there is a step forward. So in 2012, ESPGHAN put forward the new diagnostic guidelines. We have heard about that, so I don't need to go through them again. So I'm most excited about the fact that I hope in fewer than the next 20 years, we will be seeing progress. And of course, what Knut Lundin has presented us is very exciting, especially the possibility of doing either with the tetramers or other techniques, doing diagnosis quickly without the need for a gluten challenge, or at least with a short gluten challenge and no biopsy. I think we are getting there, and then the proteomics and all these omics, but I'm too old to manage omics, so I remain firm on clinical grounds. But I like also what Knut said, let's also remain focused on the patient. In the future, maybe we'll have to fine-tune and modulate our diagnostic approach depending on the patient, the age of the patient, the comorbidities, and many other factors. So we might have a personalized diagnostic process for each patient.
Thank you, Dr. Guandolini. Maureen, I hope you are not encumbered by the sins committed in 1969, which probably predated your birth. So,
of course, obviously.
What are you most excited about?
Yeah, I wasn't there for that.
That's
but
right.
I'm here
That's
now.
right. You have no blame. So, what are you excited about?
So I think, you know, echoing what Dr. Guandolini said about sort of a shorter gluten challenge, you know, I hear from so many patients that do want to know whether they have celiac disease, but maybe they can't, due to severe symptoms, really sustain a long gluten challenge. So having some sort of serum or, you know, IL-2 that could help patients, you know whether they had celiac disease. I think that's sort of what I'm most excited about. The other piece is some of these other sort of options for endoscopy that might remove the need for anesthesia. So whether that's using video capsule endoscopy, more using a transnasal endoscopy, or some of these capsules on a string, I think that may be really helpful in helping us learn more about healing and mucosal recovery. And I think we need to do that. So I'm hopeful that those will also continue to develop.
Thank you. Knut, how do you feel obviously you brought up 2 very important issues, frontiers, the tetramers, but also the proteomics. I guess picking up from where Maureen left off, she talked about, let's say, user-friendly endoscopic approaches. Clearly, that presents a challenge for proteomics-based biopsies, right? So how are you thinking about that?
It does, although I'm continuously surprised by by the problems that people think of when it comes to endoscopy, because I'm an endoscopist myself, and I do in Norway we do almost all endoscopies without sedation, and local anesthesia, and colonoscopies without sedation is completely irregular. So it's but we can leave that. Well, I think that the most exciting thing is after all the widespread use of transglutaminase 2 testing, antibodies to transglutaminase 2, which is just, I mean, we pick up so many patients now because it's easy, it's accurate, it's then you can discuss, do you have to go on with a biopsy? So far we have been doing that, but after all, it's as a medical test, it's just fantastic.
So
honestly.
may I ask, if you were to get somebody who walked in with a sort of over-the-counter antibody test, would you take that seriously?
I would do that. I would. Point of care test. Yes, of course. I would take it seriously, but I would be reluctant to make a firm diagnosis based on somebody who shows me a point of care test. I would repeat it, but
Yeah, no,
yes,
that's
of course.
Okay.
Point of care testing is also well, it's fine, although we do not know how many patients who do the test. It's not widespread in my country. It's not widespread, but the concern is that the patients do the test and then decide, okay, well then I have celiac disease, and then go on their own, which I think is not good.
Sure.
Celiacs should come to our healthcare system. We should treat the celiacs as we do with the IBD patients. The major difference between celiac disease and IBD is, of course, the industrial support and our focus on in the IBD field. But the celiacs deserve as good a treatment as the IBD patients. That's my honest thinking.
Thank
I
you.
think we would all agree with that on this panel, that celiacs deserve. But follow up on that question though, Dr. London, would you then, if you have this abnormal TTG with the testing, would you proceed with an endoscopy?
You mean after a point of care test?
Yeah.
Yeah, well, for me, it's very easy because we will do an endoscopy now and we will repeat the serology. So as easy as that.
Thank you.
But, still, again, I mean, we have a public healthcare system, so the payment is not an issue.
Right.
I mean, on the individual basis.
Joe, you're about the closest in our country to having socialized medicine in your part of the world. How do you, what are you seeing as the future for diagnosis and diagnostics?
If you mean by that, does the state of Minnesota try to protect the rights of its citizens and residents to healthcare? Yes, we are different from any other states in the United States, sadly. I would like to point, from my perspective, I mean, what the most exciting is, as the data accumulates on the accuracy of serologically based strategies for diagnosis, will make it easier, more accessible. That, of course, is also the challenge, because we have people who still make diagnoses here on the basis of an abnormal total IgA. It comes up as part of their celiac panel. It's red. So they call it celiac disease with a negative antibody test. So we are faced with a huge knowledge gap. If we can bridge that knowledge gap, then it will make life much more accurate for our patients with celiac disease. And, the 10 times upper limit of normal, I mean, that's fine. It's probably even a little high, and you can use combination testing. I like the endomysial antibody. If that's a positive along with the TTG of, say, twice the upper limit of normal, that's probably will also work out to be just as accurate or predictive as the TTG IgA alone. There are issues of accessibility to the EMA testing, but to me, it's coming up with ways that make our diagnosis much easier. The challenge, of course, is the communication between the ordering physician, the laboratory, and then the interpreting physician and the patient, if they're the same.
Very interesting. And Dr. Troncone, and last but not least, how do you see the most exciting frontiers on the future of diagnosis?
Can you hear me?
Yes.
Okay. I'm fascinated by the shift of the diagnosis from demonstration of alterations in the gut to the immune response. So first serology, but even more tests based on T cells and cytokines. I'm fascinated because that put a question about the nature itself of celiac disease. Is it an immunological disease or is it a disease affecting the small bowel? I'm particularly interested in that also because my interest in potential celiac disease. Is that a condition, a disease condition or not? And from this comes also if the test on demonstrating the presence of T cells can be used, you know, for in all cases. We know, for instance, that in potential celiac disease, we have T cells. Nobody has used tetramers so far to count them and to demonstrate them. But if so, I mean, that I repeat, puts questions about the diagnosis.
So if you had a child referred to your clinic who had a tetramer-based diagnosis, but no endoscopy or more conventional symptomatic things, how would you react to that? I can't imagine that would happen today, but let's say in the spirit of thinking 10 years down the road, what do you think? How would you react?
Unfortunately, this is just a technical remark.
Yes.
It's very difficult to use tetramers in children because the large amount of blood which is needed. But apart from that, if he comes, I would I mean, I would say that he certainly belongs to the spectrum of celiac disease, but I'm not sure if he's if a full disease. He has T cells, which is a feature of celiac disease, and not of other conditions, gliadin-specific T cells. But I do not know if he's really affected or not. I mean, from the clinical point of view. So for this reason, I think that although it's fascinating, a diagnostic based on T cells, we have first to understand where the disease is.
Dr. Verma,
I'm not sure if I was clear.
Yeah, no, this was very clear. Thank you.
So I think this is exciting in terms of what's exciting for everyone, but let's go to what do we have currently. So I know there was a question in the chat that Dr. Guandolini answered, but I'm going to pose it to everyone again. So the question was, what's the benefit of doing an endoscopy in a 12-year-old who has a dad with celiac disease, who has genetics, not specifically know what genetics, but I'm assuming it's one of the HLAs, with some 5 cavities. What should be done for this child if this is where this is the scenario? So I guess I'm going to go to the pediatric folks. So Dr. Troncone or Dr. Leonard, and then Dr. Guandolini, you gave your opinion, but we'll come back to you as well. But perhaps Dr. Troncone.
I just want to apologize for having answered that, but it popped up and then it says type your answer here, and I just went on and typed my answer there. So, but
no, and that's
cute now.
No, that's totally fine, because now we have your opinion and we're going to get the opinions from Dr. Troncone and Leonard. So what would you do if you had this 12-year-old come to see you?
So I understand that he has only genetics and some clinical symptoms. I understand.
Yes, and a dad who has celiac disease.
I mean,
based on the question. So we don't know if there's anything else. This was a question in the Q&A.
Okay. If it has only the genetic predispositions, so the positivity for HLA-DQ2-DQ8 is not enough to proceed. So I think that it would be very important to have a positive serology in terms of antibodies. specific antibodies. Although I must say that, but I don't know if this is the case. But whenever we face a case with a strong clinical suggestion of disease, we should proceed anyway, irrespective of the serology. But in general, this is quite rare. In general, I mean, we act only following the positive serology.
And Dr. Leonard, I know you had outlined in your slides what your workflow would be. So what test would you advise this family?
Yeah, so as I mentioned, we have a cohort of over 500 children that we follow that have a family member with celiac disease. And when we look at their genetics, about 90% carry one of the genes or a piece of the gene. So I think I would say, first of all, it's very common that when there's a parent that has celiac disease, that a child is going to have the genes. And then in this case, as was mentioned, you know, when there are signs that are really concerning for celiac disease, we would move forward with the endoscopy anyway. So having cavities is a sign, but it could be a sign of many things. So that's not one where I would suggest that an endoscopy be done. I think we'd need to look at whether there were other symptoms and also look at growth. And if there are really no other symptoms and growth is on target, then I would say they're kind of I wouldn't do any further testing, and I would say they're at risk of developing celiac disease, as we already knew, because they have a family member with celiac disease, and they should be monitored with an IgA TTG level every couple of years or sooner if symptoms develop.
Thank you. And Dr. Guandolini, anything that you would like to add?
Yeah, no, I just want to add that in the question, the mom says, should I just go on a gluten-free diet? And so part of my answer was I would never, under no circumstances, initiate a gluten-free diet without first having a clear diagnosis. You cannot commit to a diet for life on a permanent, incurable disease based only on the fact that the dad has celiac and the child has some cavities, because this is what was said in the question. So it's most important to stress if there are participants that are not in the medical field, that you should never initiate a diet without having at least a confirmatory test initiating the process of diagnosis for celiac disease. Then we can discuss about with or without biopsy. And I feel totally and strongly in support of the ESPGHAN guidelines that provide, under definite circumstances to avoid biopsy. I don't think why we should do it. I mean, after all, we don't do a biopsy of the pancreas to diagnose diabetes. Why do we necessarily have to do the biopsy for celiac? We just discussed this. But the question, I really wanted, the part of the question I wanted to stress again, do not initiate a diet without having a diagnosis. The genetic test, as we know, is just to rule out celiac when negative.
Thank you. Any comments from others? Dr. Khosla, anything to comment on this?
No, I think this is really good advice. I guess I am, Knut, you brought up the question or the topic of the importance of bulb biopsies, biopsying the bulb. And I guess, is there, do any of the other experts want to chime in on that subject, both in the context of diagnosis, primary diagnosis, as well as in the context of ongoing disease?
I can only say that I think that emphasize the difficulties that sometimes we have with histological evaluation. And so, I mean, I would be very careful for diagnosis based only on bulb, alterations. And again, I mean, this emphasizes the difficulties and the fact that histology is not so simple as it seems.
So
I'm sorry, go ahead, Dr. Khosla.
What would you encourage the patient to do?
In the case of only bulb.
Yeah, in the case of Knut's hypothetical, not hypothetical, real case.
He was a real case.
What Knut said leads me only to a consideration that we are only, I mean, that we know about the very large heterogeneity in terms of clinical and histological features of celiac disease. But we are treating all in the same way, as Knut has underlined. And maybe we are at the beginning of an era where we can base it only also on other markers, RNA-seq or other things that the expression studies, that maybe we can dissect more and probably have a different approach. For instance, in this case, where maybe malabsorption is very unlikely, we can, behave in a different manner. But so far, this is not the case, but in the future could be.
Maureen, do you have any thoughts? Oh, I think Maureen may have.
Yeah, I raised my hand just because I agree with the real difficulty in making a diagnosis when it's when we see only histologic changes in the bulb. And for that reason, I separate the biopsies that I take from the second portion of the duodenum and the bulb, and I send them. And when I have a patient that just has changes in the bulb, I typically review that with the pathologist and kind of try to put everything together just to get all of the information and look, and are there IELs there and how does it look? So I wonder if others in the group also separate their biopsies, or how would they or the patients even know that their damage was only in the bulb if you don't separate it or review it with the pathologist, because I think most might not comment on that.
I agree with Dr. Leonard in that separation, if you have anything above a background risk of celiac disease, it's probably best to separate them. Absolutely key in the bulb is, are there Brunner glands that are distorting the mucosa from below, because that can completely fool you in terms of the architecture.
I would agree on that. Always separate the biopsies, otherwise you get really confused. But in this case, it was the composite setting that I wanted to discuss with you. It's a family history, positive serology, not high, but still two different serologies that are positive, an effect of a short-term gluten-free diet. He was back on a gluten-containing diet, and then typical histology in the bulb. So this is a real case, I can assure you that.
Sure.
But how can these factors explain clinical symptoms? That's my maybe a main message. And my thinking is that we have to rethink a little bit about the different aspects of the diagnosis and heterogeneity of the patients. Yes, of course, some patients have bone disease. There's an issue with white matter, gray or MR findings in celiac diseases. Rather complicated.
Dr. Verma, we have 3 more minutes in our panel before they shut us down. Do you want to take that last orphan question about non-celiac gluten sensitivity, or do you feel that's not something that could be addressed in 3 minutes?
I think we could take it and do a real fast. Everyone only give a few seconds each, a quick answer. There will be more.
Joe, we'll start with you.
Yes, there we go.
This is a question about gluten sensitivity or non-sensitivity.
Diagnosis.
Can you comment on the difference?
NCGS.
One of them, that is celiac disease, is associated with gluten. The other is not. It's related to FODMAPs and probably functional gut disease in the great majority of patients. A small proportion have nearly celiac disease. They carry the HLA type. They might have low-level antibodies, and they may have increased IEL, so that's a questionable issue.
So we saw a few thumbs up, so I won't ask them. Is anybody scratching their heads about Joe's response? Speak up or hold your peace forever.
No, I just want to endorse what Joe said so nicely and clearly. It's a mixed bag. Yes, some of them may be early onset and still undeclared celiac disease. Some others, perhaps 99%, are a mixed bag of FODMAP or ATI or even placebo-nocebo effect. I mean, there are studies that have shown this very, very clearly. The real culprit of gluten has never been shown beyond any doubt, and certainly not in pediatric age. So the first thing I would recommend is to begin changing the nomenclature from NCGS to NCWS. This is a non-celiac with sensitivity at best, but gluten is guilty for celiac, but has never been proven guilty for this condition. Let him out of the way.
And certainly is more a problem of adult gastroenterologists than pediatrician.
So we'll hand it back to Joe and Knut to worry about this and not us in pediatrics.
What I can say, I can just chime in. And after the reimbursement for gluten-free diet for non-celiac gluten sensitivity, after that was discontinued in our country, the whole disease disappeared. So we don't see it anymore.
How did you do
as
that?
a gastroenterologist?
Not surprisingly.
No.
Well, we'll have to learn the tricks from your country.
Well, we never had reimbursement for celiac gluten.
No.
That lever is not available to us.
Exactly.
On that note.
Indeed. So thank you very much. This has been very interesting. And I think just like with our first session, what we need to do is we know a few things, we don't know a lot, we need to know more. And in 10 years, we'll be doing different tests than what we're doing now. I think it'll be an exciting time to learn a lot of new things. So thank you very much, appreciate it. And then I'm going to hand it over to Rachel.
Thank you. This was an amazing discussion. Thank you, Dr. Khosla and Dr. Verma for leading our panel, and thank you to our panelists. It's always amazing to see everyone, and having our founder of the center, Dr. Guandolini, on. It was fantastic.
Thank you.